Hello everyone and welcome to today's webinar, Trauma Verification's June Q&A web conference. Before we get started, I'd like to go over a few items so you know how to participate in today's event. You have joined the presentation using your computer speaker system by default. For best quality, we recommend dialing in by telephone. To dial in by telephone, just select telephone in the audio pane and the dial-in information will be displayed. I'd now like to introduce Tammy Morgan, Manager of Trauma Center Programs.
Hey everyone, thank you for joining us today. This is the Trauma Verification Q&A web conference. This is brand new for us and we are so excited. I have to tell you, we get in our inboxes just inundated with questions from you guys, and we thought we do this very successful with TQIP, and it's really made a difference with us and with you all, and so we thought this would be a great thing to offer those folks going through complying with our trauma verification standards. And so I want to let you know who's with me. I have Molly Lozada, the Verification Manager for Trauma Verification, and I also have Rachel Sanchez, the Site Visit Coordinator for Trauma Verification. So let's talk about trauma quality programs. If you notice on the previous slide, I have us down as trauma quality program staff, and that's something a little different from you because what you've known historically is trauma verifications, TQIP, and PIPs. And now what we are trying to do here at the college, we've been working hard the last 2 years to integrate those programs so we don't seem like to you that we're working in silos. Not that we really are, but I can totally see how it could seem that way sometimes. And so an example I can give you of how we would work together is the first step that we've done is we've kind of reorganized ourselves here at the college. And, you know, one of the things that you do if you're going to have a trauma verification site visit is you're going to have a contract. You're going to pay somebody. And if you're in TQIP, you're going to have a contract and you're going to pay somebody. So one of the ways that we've integrated is we have verification staff, and we have trauma operations staff. And so, you know, it's going to be those same folks that you're going to talk to and setting those types of things up for your, whether it's you want to join TQIP or you want to be verified as a trauma center through ACS. And so it made, what you'll see in the future is a different way that you're going to pay. You're going to pay for everything kind of bundled if you're in both of those programs. And that's just one of many examples I could give you. You know, another, if you've been in TQIP, then you have probably heard us say that we want to, with TQIP, enhance your PI program at your trauma center with it by using our benchmark reports and the information that you get back from us. And so that's another way that we're doing this. And so you'll hear from us throughout the year many things that you'll be able to see on how we're integrating our programs. But I just wanted to speak to that just a little bit because it is a big change. So what is the goal for this webinar? It's for you to interpret the standards that are in the resources for optimal care of the injured patient manual. That's the orange book, right? We want to make sure that you have a clear understanding of those criteria so you're able to provide good quality care to the injured patients as the other hospitals do that follow those standards. And the other thing is we want to make sure that you have an understanding of our processes and standards involved in the verification site visit process and how they you know, positively impact the quality of care of the injured patient again. So moving forward, let's get started. I'm going to pass this presentation on to Molly Lozada. Molly, there you go.
Hi everyone, and thank you for joining my very first live webinar. So please excuse any over talking on my own part. So I am going to get started, and the first thing I'm going to talk about is if you happen to have a copy of your orange book with you, that'll be great, and if you don't, you can certainly go to our website. The link is noted down below, and either work off the PDF copy unless you have that already saved to your desktop. So I want to let everyone know that we are recording this webinar. it will be available soon on our website. As you see there's the link. I also want to remind folks that we are offering CE for the nurses, and in order to get the CE, you must participate in this webinar for at least 15 minutes, so that way it is in compliance with our requirements. So with that, I want to talk a little bit about the disclaimer. Just want to let everyone know that most of the questions that we received were based on the survey that was sent out to folks, and there were no edits made to the content of the question or any typos or misspellings. We just kind of grabbed it and went along with it. So there were duplications of questions, and if that's the case, please don't worry. I will definitely answer your questions shortly after this webinar within a week or so. And so again, any unanswered or any duplication of questions that were maybe specific to your trauma center, I certainly will follow up with you shortly after this webinar. So with that, I am going to introduce Rachel Tanchez, who is the site visit coordinator for scheduling.
Good afternoon, everyone. We'll start with the first question. It's a scheduling question. Okay. So the first question is, if we are seeking adult level 1 and pediatric level 1, how many surveyors will be sent for each program? Well, if you're having a verification or a re-verification visit, the standard team that will be sent is 1 pediatric surveyor and 2 general surgeon surveyors. But if it's a consultation, you can add a nurse to that team above. And then also you just want to know if your state mandates additional reviewers, or if you have a surgeon that's requiring alternate pathway, you'll have extra reviewers added to the team. The next question is, what is the schedule for a focused review? So a focused review is basically it's a half-day review, which will start at approximately 7 a.m. and last till about noon. There will be 2 reviewers. At least one of them will be returning from the prior visit. And at the focused visit, there's no PRQ, there's no formal dinner, and there's no tour of the hospital facility. So basically, the team will be there to review the CDs cited from the initial visit, and you will only need to pull cases in response to those CDs, and only commencing with the changes. So the day will begin basically with the presentation on the corrective actions taken to address the deficiencies and weaknesses. And just a side note, the correction action plan should be submitted through email to our office 30 days before the visit. Then the next, what will happen is the chart review process, validation. Then there'll be a closed meeting with the reviewers, and then the exit interview. And all of this is listed in the focus review agenda and can be found at the link below. The next question is in regards to electronic medical records. The question is, do reviewers prefer having the EMR printed? Well, as mentioned on page 6 in the reviewer agenda, we prefer that you contact the lead reviewer for their preference. We have over 140 reviewers, some old school, some new school. If they prefer paper medical records, just be sure to print out all that is needed, and that's listed in the review agenda. And if your lead reviewer prefers electronic medical records, you'll definitely want a staff member who is proficient and able to navigate the EMR software. The next question refers to site visit scheduling. When will we get our visit dates if we are expired in April 2017? Well, we ask centers to send in their application 13 to 14 months in advance of your requested time frame. This doesn't necessarily mean that you're going to get your dates a year ahead of time, but it's definitely there to hold your spot in that month. The time frame is requested by you, and that's the time you will be scheduled for that visit. We aim to have your visit scheduled by 90 days before your visit. For example, if you expire in April 2017, you may have requested a time frame of March on your application, and I would aim to have your date for you by December 2016 or early January 2017. Okay, next will be Molly to answer some general questions.
Okay, so we got some questions based on just non-CD questions, and then we have another segment where it's related to the PRQ and some requirements. So with that, here are some questions about how are FAST exams performed at a specific hospital or in general any hospital. And this question actually, it's going to vary. It's going to vary upon the trauma center and what their process is. So as you can see here, some hospitals have a formal process where they would credential all their providers that use ultrasound. Other centers will have regular meetings where they will review the ultrasound results and then present that at the Emergency Medicine Quality Improvement, which we refer to as PI, meeting, or they can present it at the trauma peer review meeting. So it can vary among trauma centers. Moving on with PRQ questions, if I am not a pediatric trauma center, do I still need to complete the 3 pediatric filters? I want to say that we are currently working on our PRQ questions in real time, meaning that what you've downloaded in your PRQ as a Word document or what Anita may send you as a Word attachment, it may differ from that what's on the website, and that's because we are working in it in real time, making edits as we move forward with our own performance improvements. So the response to this question is if you're an adult trauma center that does not admit pediatric patients, you do not have to complete that question, and again, that question will probably be eliminated shortly. And speaking of our PRQ, the PRQ, again, it is available in Word. It's available on our website, at the resources website that we had the link presented earlier in the slide. And again, we're going to work on that. We're going to have various copies of the Word document by level and by population, meaning a pediatric trauma center will have a specific PRQ in Word just for pediatric patients. Yay. Peer review meeting. If we're seeking a combined adult level 1 and a pediatric level 2, and this would be the same for a level 2 adult trauma center and a level 2 pediatric trauma center, they're asking if they need separate committee meetings. The answer is yes. Yes, yes, yes. So reviewers will be looking to see that you have separate minutes, meaning you have to have separate minutes for your adult meeting when it starts and when it ends. And then you will have separate meetings for your pediatric meeting when that starts and when it ends. I do want to say that you do not have to have these meetings on separate days. They can be done at the same time. We need a start time and an end time for both of those. Minutes, it could be in a summary format. It could be in an outline format. We're not asking for very descriptive or very detailed minutes. We're asking for a summary on how that's presented at your trauma peer review meeting. Question is about backup surgeons. I get a lot of questions on this, whether or not they are required to meet the same standards or the 50% trauma peer review meeting. The answer is no. The trauma peer review is primarily for the trauma medical director and the liaisons and those appointed to represent them in their absence. Locums. Another question, tons of questions on this. I know there's been various answers out there. So I do want to talk a little bit about this. So locums, if you have locums on your trauma panel that are seeing trauma patients, they are required to meet the same standards as your other trauma panel members. That is regardless of the frequency. So if they're there 1 weekend a month, if they're there a couple of weekends a month or 1 day a month, again, they're expected to meet the same standards. For example, if they are there for 4 months, just say 4 months for the summer, covering a couple of times a month, the expectation is that if they're there 4 weekends, one for 4 months, they have to meet at least two meetings to meet the requirement. Question about pediatric trauma program managers. They're pursuing level 2 PEDS. Just for reference, the ACS does not designate. We verify the standards. Designation is done by the state agency or county agency. But I do want to say that for a level 2 pediatric trauma center, the pediatric TPM cannot also serve as the registrar. They may serve as the injury prevention coordinator, so they can do both. So as you know, the registrar the requirement for a registrar is 1 FTE, so that's really the purpose why the TPM cannot serve both roles. Taxonomy. How much incorporation of the new taxonomy is expected in the review? Currently, there are no requirements to use a new taxonomy for verification purposes. I'm going to ask Tammy if he has anything further to add to this.
Yeah, I do, Molly. Thanks. This question concerns me, and the reason why is we don't have a final new taxonomy yet. Something that in our PIPS program, Performance Improvement Patient Safety, that's a program that we have 4 work groups that we're working on, some different components, and taxonomy is one of them. And we do have a draft of that, but this taxonomy is going to be piloted, and we have not even got that far yet. So it concerns me that it's out there, and somebody is possibly working off of that when we haven't even launched that yet. And so know that we do not have a new taxonomy yet. We certainly are working on it, and we hope to be able to provide that to you. But we're not ready for that yet. So it certainly was not going to be expected in a review anytime soon.
Thank you, Tammy. Geriatric permissions. Another question I get often. Some centers are keeping geriatric isolated hip fracture patients in their registry. Is this going to be a requirement in the future for all? I want to say yes. The reason being that this patient meets the inclusion criteria for the NTDS, the National Trauma Data Bank Dictionary. Again, this for verification purposes, we do want you to capture that data. I do know that there is a sentence in the PRQ that we are going to fix that literally says do not include them. Please excuse us for that error. We will address that. And I also want to add this may differ from what your state inclusion criteria, because sometimes you may be working off two inclusion criteria, one for verification purposes and one for the state. So, so there may be times where you're working on, double entry or maybe additional data fields that you'll have to collect, but we do want you to capture that. And, and if you're not capturing it, we certainly want you to start capturing that. And also for areas that are densely populated by geriatric and, patients or elderly folks, I think that'll make a great injury prevention activity for those centers that are looking for some ideas on what type of activities where the ACS is wanting to look at. So that'll be a great idea. I had a question on dental surgery coverage, and I'm not sure if they meant oral maxillofacial or if they literally meant dental surgery. So I put it in here, and it is not required. So dental surgery in general is not required, but oral maxillofacial is. So there is content coming up about that. TAG. Upon release of the Orange Book, this was huge. It was a huge question. A lot of people asking about it. There was concerns that it was required. At this time, it is not a requirement, and it's also noted in our clarification document that it's not. Questions about the surgical director. Does the surgical director of the ICU have to have boards in critical care? Yes. For level 1 trauma centers, the ICU director must be board certified in surgical critical care. Again, let me rephrase that. It's for level 1 trauma centers that they must be board certified in surgical critical care. For level 2s and level 3s, we're not asking for them to be boarded, but if they are, that's great. I do want to say that for level 1 pediatric trauma centers, there is a variance. Again, that is noted in the clarification document. Level 1 pediatric trauma centers do not have to have, the ICU director does not need to be board certified in surgical critical care. They have variance for that. Please refer to the clarification document for more information. Documenting response. I got a question about how what methods are institutions using for reporting the neurosurgery and orthopedic response? If it's self-reporting acceptable? You know, ideally, we don't want to see the trauma surgeon or the neurosurgeon or orthopedic surgeon doing any self-reporting on their times. Ideally, we want to have a scribe do that. If they were requested to consult to the trauma bay, we want a scribe to capture that. Or in some instances, if you're a center that has a key scanner, that is awesome, because at the time of the site visit, the reviewers will possibly ask for a report on that. Arrival time versus outcome. Why is the emphasis on subspecialty arrival time in the ED versus outcome in those patients? I think the emphasis here is that the idea is that the focus is getting the patient optimal care at bedside as soon as possible. You know, that's key. You know, that's why subspecialties have an arrival time, and that is documented. The second part of that, patient outcome, is benchmarked through the TQIP process. Right now, I'll let Tammy talk a little bit more about that, but we don't benchmark in the PRQ per se. We're just asking for data that the on-site review team can verify at the time of the site visit. Tammy, do you have anything to add?
Not really. I mean, it is true that the outcomes is benchmarked through TQIP, and you can look in, for those of you that are in TQIP already, you can certainly look at the back of your benchmark report. There's appendices in the back, and it will show you exactly how things are filtered for the report, for each cohort, for each section of the report, and so I really don't have much more to add than that.
Okay, no, thank you. Non-core surgeons. Questions. A couple of questions on non-core surgeons. Just want to let people know that we did away with the word of non-core surgeons, not necessarily them in general, but just the usage of the word. So the question is, non-core surgeons, are these not being allowed? Is there a difference between adult and pediatric programs? Well, obviously there's differences between an adult and a pediatric program. Again, we did away with the non-core wording. We were just saying that all trauma surgeons are held to the same standard and are going to be accountable to respond to the hospital policy. But yes, they are allowed. As I said here, ACS no longer differentiates between the non-core and core. They're all considered core now, but there's no difference in the adult versus pediatric programs. Pediatric permissions. If our facility admits low acuity 16 to 17-year-olds, do we include these patients in our numbers or stick with the less than 16 years of age? For verification purposes, I would say, if the pediatric volume is met with the high acuity of less than 16 years of age, then the low acuity 16, 17-year-olds should be included. There's no right or wrong answer here. I think if your state pediatric admission is higher than that of the ACS, we want you to capture that in the PRQ, because the reviewers are going to see those cases when they're on site. So it's okay to include them. I think you just have to disclose to the reviewers that, your data reflects, 16, 17-year-olds, and, basically the reviewers are going to want to confirm that your volume meets the, the 100 or 200 patient admission for the requirement. Pediatric protective services. Question for level 2P center, child protective services program. Are we asking, is there a requirement for board certification for these positions with child abuse specialty? We don't have any requirements on this. We don't You know, I think the important thing to take away from this is that the Trauma Center is certainly credentialing these providers to provide child abuse care when the need arises. But, you know, we just don't have any standards around this right now. It's not to say, that, you know, in the next iteration of the Orange Book it may come up, but I'm seeing this more and more often now. Trauma call versus trauma panel. Define trauma call and trauma panel as it relates to pediatric general surgery, neurosurgery, orthopedic, PEDS, EM, and PICU. Let me say the terms are interchangeable for maybe for me or for the ACS in general. Some centers have different terminology for this, and that's okay. We don't, we don't favor one over the other. But I do want to make a, just say that trauma call is, can be defined as any surgeon who has been identified to respond to the trauma codes, where the trauma panel would refer to, your trauma surgeons, general surgeons, and your other services. So again, the term is interchangeable for us. 30-minute consult. So several questions on the guidelines for the 30-minute response time for the urgent consults to neurosurgery, orthopedics, angiogram, and what exactly that means. And a lot of questions on who can respond to those as well. The 30-minute response requirement is for their response to come to the bedside. We're just asking, so the 30-minute actually is just, the call is made for them to come, and they have 30 minutes to get from where they're at in the hospital or from home to get to the bedside in 30 minutes. And once they're at the bedside, then of course, we're expecting them to assess the trauma patient. Level 3 consultations. In a level 3 facility, is there a time frame for the trauma service to see the patient when consulted from ER for admit? This will depend, and this doesn't necessarily, it's not necessary for level 3s. This is for 1s, 2s, and 3s. The Trauma Center is going to define the policy for their trauma admission, and what types of injuries is going to be captured in that policy for the consult. And the expectation is that, during a site visit, that the review team is going to verify that the center is adhering to its admission policy. So the time frame, the types of injuries is going to be defined by the Trauma Center. Dead on arrival. This is also another one of those questions we get a lot on. If a patient arrives to the ED with CPR in progress, has brief ROSC, couple minutes, more CPR, and dies in the ED, is this considered DOA? We don't have any guidelines or any criteria around what a DOA is. I know there's been some challenges with that. I don't know if Tammy wants to add a little bit to that.
I don't know if some of you may remember that had been in participating in NTDB for a while or been in TQIP, but we used to have a data field that included DOA and kind of defined it, and just nobody paid any attention to that definition. And so when you looked at our data, it was bad data because you would have patients that were, at the hospital for, like 45 minutes, an hour, which is not exactly dead on arrival, or at least something's wrong is happening there. And so we just kind of scratched that data field, and so that is something that has to be, defined at your hospital. What we chose to do to get some better data is to have you just tell us were there signs of life on arrival or not, and we tell you in our definition what signs of life are. And so in determining what you want dead on arrival to be at your hospital, you can certainly go to that data field in the data dictionary and see what, how we describe that. But we certainly don't define DOA.
Thank you. And I will have the web address for the NCDS data dictionary in a couple of slides here, but that's great. Thank you, Tammy. ENT and OMFS call schedule. Question is a separate call schedule mandatory for ENT or is OMFS combined trauma panel meet ACS expectation? Great question. We get this. I get this a lot. Yes, it can be combined. I know during some site visits, some reviewers want to see the call schedule, but it's okay if you have a combined call schedule for both these services. Gap analysis, again, another great question. Is there a gap analysis available for level 3 and level 2 trauma centers? The answer right now is no. I don't necessarily have a gap analysis available. However, I think this is something that I'm going to work with my team to possibly develop one soon, because I think this will be a great tool since we're seeing a lot of level 3s upgrade to level 2s. So I think this will be a great incentive for us. TQIP antibiotics. Several questions on this, as you will note. Let me read the question. When will the ACS be looking for antibiotics within 24 hours after arrival for open fracture as a TQIP benchmark? Let me just, before I pass this on to Tammy, I do want to say that those folks that are familiar with our PRQ or have recently had a site visit or currently in the process of a site visit, this is a question in the PRQ. It does not tie in with a deficiency. We're gathering data on how the hospital is handling these patients and how the antibiotics are being administered. So again, there's a question in the PRQ, and we're just looking for an average time of how the center is administering those antibiotics. Tammy?
So yeah, so we think that in the future that we will possibly have a data field about this, but I can't tell you when. At this point, you know, I know that I'm not really going to take the time to explain the whole process of the NTDS data dictionary, but you know, we usually have that data dictionary completed a year before you get it. Pretty much. There's so much that has to happen, and like I said, I'm not going to take your time to explain all of those processes, but we do have a group of orthopedic surgeons that we're having discussions with, and they're very excited to work with us, and so we have all the other data fields that is needed to work with them on some benchmarking for ortho, except for this one. So I kind of, you know, I have a feeling this is going to be a data field in the future, but it's certainly not going to be anytime soon. So the soonest that today, if we were to say today that we want to add an antibiotics field, then the soonest that would be out to you in the form of the data dictionary would be for 2018 admissions. So we have to have all of our ducks in a row on this end. We have to give it all of the information to our vendors, and there's just you know, several processes that have to happen. And so it may be in the future, but not anytime that soon.
So I also want to add for this question in the PRQ, there are going to be times where Megan will reach out to you because of the way the answer is noted in the PRQ. The orthopedic group, as Tammy mentioned, reviews our reports, and they look at these specific data fields in the report. And if the answer is questionable, then Megan will definitely reach out to you. So please don't take offense to that. You know, we're just wanting to clarify the expectation and what truly is being done at your hospital for those time sets, or for these patients rather. TQIP benchmarking report. I'll talk a little bit about this, and then I'll give this over to Tammy. Will you be using TQIP data during our re-verification visit, even though it is old information? Yes and no. So my part of this is that I want to let folks know that, yes, a summary of your TQIP report, which we call a primer, is provided to the review team prior to your upcoming site visit. Again, it's just a summary, one-page document that is provided to the review team, and of course the center may, you know, have a full copy of their TQIP report readily available on site for the team for them to drill down on that.
Yeah, so let me tell you about the conversations that go on here as far as we are integrating, as I mentioned earlier. And so, TQIP and verifications are on a very high staff and surgeon leadership level, or having the conversations on the best way, to integrate TQIP and verifications. And one of the things, it's not about, yes, verifications are going to provide the reviewers with a summary of your report, but it's not about what the status is, what your status is on the report. It is about whether you're using your report in your hospital. That's what they want to see. And so every site visit may be a little different based on the reviewer, based on whether you are using your TQIP or not in your report. And this is something that's fairly new for us. And so, it may look completely different a year from now, what those site visits and how much discussion is around those benchmark reports. But that's what it's really about, is are you using, the reports at your center, not so much, measuring or looking at what your status is. And your verification depends on a status. That is not it at all. So no worries there for that.
Correct. I also want to add, as Rachel mentioned, there's 140 site reviewers, and as many of you probably know and been through the verification process, each reviewer is unique and have their own criteria or their own areas of expertise and their interests. So some reviewers may, if you don't provide them a copy of the report, they may ask you for it. So we're just pretty much letting folks know in the review agenda to go ahead and just, have it available for them to see. And if they don't ask, by all means, just, tell them, hey, do you want to see it, and go from there. So I have some CD-related questions this next segment. We'll start with the Trauma Registry. And the question is, what is the best method for validating the registrars?
So that is a good question, because you rarely find anywhere, what that best method is. And if somebody is telling you there's a best method, who are they? And so I can just give you some examples, because what I feel like it kind of determines about what the needs are at your center for abstraction. And as soon as for validation, as soon as you start validating, you may yourself determine, well, hey, here are the needs. And so I can tell you what's important is, and one example that we give you in Chapter 15 in the Orange Book is to re-abstract. And so do you have time always to re-abstract? You don't. I know from doing TQIP validation visits, I can tell you that validation is the first thing that gets dropped, I can also tell you, if you don't validate your data is wrong in some way, because, we're just all human. And so maybe you can't re-abstract the whole chart all the time, but maybe you can re-abstract what's important to you in your chart. So what's important is the chart abstraction portion. It's also important the registry entry portion of the registrar role, and then the coding is super important. And so what do you code? You code E-codes, or what's now called external cause codes. You code injury, ICD, and in AIS. You code procedures. You code the site of injury. And so those are things that you can focus on. And so examples, like I said, of how to validate is re-abstraction. Use reports. If you find that you have, in running reports from your registry, that you have some issues with dates, run a date sequence. That is often a very simple way to find errors. Use your validation reports. When you submit your data to NTDB, I don't know if all of you are aware, because it's often the case that the trauma registrar is the one that's submitting the data, but within 5 or 10 minutes, you get 3 reports back. Those reports are the validator, a validator summary report that shows, you know, how many patients that you that came across to us, what if there are any flag levels, and you know there are flag levels that are bad, and there are flag levels that are okay. Flag levels that are bad are 1 or 2, and if you have 2,000 patients and you have one or two flag, it's going to reject your, NTDB data center will reject your file and you'll have to go back and correct it. 3 or 4 flags are flags that for you to use for validation. That's what they're for. So use those reports. And so 3 or 4 flags don't really mean your data is wrong. It just means, hey, this looks weird. Look at this. And if it's right, move on. If it's not, fix it and resubmit. And then the last report that you get is your submission frequency report, and that kind of lets you know for all of those reports that have field values that you're choosing and sending to us, that are the field values are defined in the data dictionary. For all those data fields, it's letting you see what you reported, and so it's sometimes you can maybe work really hard at sending your hospital complications, for example, and getting those into your trauma registry and include it into your you know, data submission file, and then you look at this report and you say, hey, it says that all of our hospital patients' hospital complications are none are not recorded. Well, that probably means that there is a mapping problem. There is a problem. There's a glitch between your registry and us getting it at the data center, and we didn't get it correctly. And it's often the case your vendor creates those files for you. And so that's a good tool to use for to find mapping problems. And sadly, what happens most of all is when we send out a benchmark report, we get you know, a lot of calls from folks that don't look at these reports, and they're like, I don't understand, my report's wrong, it says, you know, I don't have any complications or whatever. And so this is a way of validating. This is a good way to use it in your center. It's kind of already done for you. And then determine important fields from your TQIP benchmark report. And that will allow you to know what to focus on. So if you, I did a slide, I think I have this slide in the TQIP online course. I know I did it at the conference last year, and it shows a table from your benchmark report. And what I did is I took, you know, and like down one side might be, you know, an ISS score or something, or a mechanism of injury, or a certain patient population, and across the top may be the different cohorts for that we use in the TQIP benchmark report. And then I show how many data fields it takes. And it's like 20 data fields it takes to provide this one table in the benchmark reports. And so, you know, through those of you that are, you know, in TQIP, through that education, you can find things like that, examples like that, but you can go with that yourself, whether it's a TQIP report or something that you use often from your state or your county, your region, something that's important to you. Figure out what the data fields are, and that's how, because some people just don't know where to begin. That's the most frequent question I get. Where do I start with validation? I don't know what to do. Well, start with what's important to you. And so those are just a few examples on how, and if you ever need more assistance, of course you can give me a shout, and I'll be happy to talk to you. Thank you, Sammy.
Next question has to do with direct physician-to-physician contact. Again, the question is, please clarify the requirement. There must be a physician-to-physician discussion on all transfers, ED physician, trauma surgeon. All of the above, and it depends. In most centers, if a patient is being transferred, there should be direct communication between the ED physician and or the trauma surgeon with the transferring center. I know in some states there are referral centers that have been credentialed to act as a go-between the two services and relating that communication between the ED physician and or the trauma surgeon. What I want to say about this is that ED is required to check with the trauma service on a case-by-case basis before accepting the transfer. That's okay. I think the intent is that we want to make sure that there is communication and it's documented in the PIPS process. The best or the ideal case would be, the trauma surgeon takes all transfers, but there are exceptions to this, as you can see here. It's going to depend on your state, process, if there's a referral center or case-by-case process. Second tier activations, lots of questions on this. What is the expectation for the trauma surgeon response with a level 2 activation? No clear time frame in Orange Book. That's correct. There's a reason for that. So as most folks know, we have the highest tier activation at 15-minute response time for the trauma surgeon for level 1, level 2s. Level 3s have a 30-minute response time. So the second tier activation, we did not put a time frame on that. We made it very vague, and the reason for that is that we want the institution to look at those patients and determine what types of injuries they're going to have the ED or the trauma attending respond, and in what time they're going to respond. So again, the policy is going to be set by the trauma center, and it's going to depend on your policy, you have to enforce it. You have to monitor that through the PIPS process, and you have to continue updating that. It's going to vary probably from each cycle, each re-verification visit you go through. So the reviewers are going to look at this on site. They're going to ask what to see your policy and what is the policy and how you're managing that. And they're going to look at it through the case reviews as well. So that's where they're picking up that. So again, the answer is there is no time for this. It's going to be determined by the trauma center. Alternate pathway. So we had several questions about the alternate pathway. There's been some changes to this. Please, again, go to the resources webpage for the most up-to-date information on this. So I'll be brief on this because this can take a bit, as some of you have gone through it. The question came in about those that have gone through the alternate pathway, and will they be grandfathered in, or would they have to repeat the process? Early on, there was some communication out that we may be requiring those folks who previously have gone through it and been approved to have to repeat it at every single site visit. We did determine that's going to be, a cost impact to the trauma center. So what the committee established in the last meeting is that for those who have previously been through the alternate pathway, we're only asking at the time of their next site visit to have the following criteria available at the time of the site visit. So it's criteria number 3, criteria number 4, and 5, and 7, as you see here. Again, this is published on the alternate pathway criteria document that's found on the resources document. So this is what we're asking to be available at the time of the site visit for those that have been through the process. Oh, and I do want to say that we will not be sending a specialty reviewer for this. This will be reviewed with the review team that you will be getting. Pediatric Trauma Medical Director. Question is, PEDS TMD must work at trauma center where program is located and take trauma call at level 1 or level 2. So what I think the question is that there is a Pediatric Trauma Medical Director at one trauma center, and they're also taking trauma call at another trauma center, maybe across town or across the street. That is not acceptable. The requirement is that they must be dedicated to the one facility, meaning that they cannot take call at another facility or 2 trauma centers at the same time. It's just it's not acceptable. You will be cited a deficiency for that. ED department coverage. What is expected by the ACS for tracking when the ED physician leaves the ED for an in-house emergency? So lots of questions on this as well. I want to say that this is a new requirement for level 2 trauma centers, in that as it says here, level 1, level 2 trauma centers, an emergency physician must be present at all times and cannot leave to cover in-house emergencies. What that means is that the ED physician cannot leave to cover something in the ICU or somewhere else. They have to stay in the department. For level 3, that is acceptable for the ED physician to go make in-house emergencies. If that's the case, we're asking that those instances be tracked and reviewed through the PIPS process. Question about ATLS. ER physicians are now being hired without ever taking ATLS. Is this an issue? Absolutely, it's an issue. All I can say to this is that our requirement states that level 1, level 2, level 3, all ED physicians are either board certified in emergency medicine, must have taken ATLS at least once. If you have physicians who work in the ED department, caring for emergency trauma patients, who are board certified in family practice, internal medicine, pediatrics, etc., any other specialty other than emergency medicine, they must be current in their boards as everyone else, but they must be current in ATLS. There is going to be a change to this. Again noted in the clarification document for level 1, level 2, not for level 3. For level 1, level 2 centers, if you have these physicians, emergency family practice, internal medicine, who completed their primary training post-2016, they cannot take trauma call at level 1 or level 2. So please refer to the clarification document for more information. Neurosurgery. Question about to clarify the criteria for level 3 trauma centers that also have neurosurgery capabilities. We're seeing a lot more level 3 trauma centers like this that are keeping neural patients, and there's requirements in the book that talks about level 3s not having to keep those patients, but we're seeing it more often where they are. And the intent is that if the level 3 has neurosurgeries, they have the capabilities and they have the equipment to keep those patients, the expectation is that the trauma center must meet the same standards as the level 2 trauma center. Again, I want to iterate that in the Orange Book, it talks about not keeping those patients, and if the case presents itself that you cannot sustain those patients, you cannot care for those patients, to transfer them to a higher level of care and review those transfers through your PIPS process. Neurosurgery diversion. Do we have to divert EMS when our neurosurgeon is in surgery or just known head injury transfer? So if the on-call neurosurgeon is encumbered, so if the dedicated or the neurosurgeon who's on call is in the OR with a trauma patient, and you know that the neurosurgeon is going to be in the OR for a couple of hours, and you happen to know there's a trauma alert coming in, the best thing is to divert those patients, or to activate your diversion policy. So your diversion policy has to, you have to alert EMS services that, you're going to be on this diversion pattern for X amount of hours, and each of those instances have to be reviewed through your PIPS process, and, discontinue the effectiveness of that process, if it happens often. Orthopedic coverage. Orthopedic response to consult states PGY4 or above. We currently have PGY2 responding. Can this need be met by having a trauma attending credential through orthopedics to respond to the PGY4? The answer is no. So you cannot have a trauma attending be the backup. For the ortho consults, the expectation is that it's going to be an orthopedic surgeon or someone from the orthopedic trauma panel that's going to come and respond. And this can be, your advanced practice practitioners, your mid-levels, your PAs, or your orthopedic surgeon. I know the Orange Book talks about it being a PGY4. Again, there's clarification in a document that talks about this can be covered by your mid-level providers or your APs or PAs. CME, internal education, lots of questions on this, as you can imagine. I've got a couple of slides on this. So the question is, can you provide examples of internal education programs that meet the ACS requirement for trauma-related education for MDs? So this is we're working with informatics on this exact requirement. They're going to help us establish some guidelines and some examples, some best practices on what reviewers want to see or what our expectations are. I just happened to finish that this morning with another a team member. But I do want to talk about, as you see here, these chapters all contain the example you see in the slide. CME can include in-service case-based learning, educational conferences, grand rounds, internal trauma symposia. The list is endless. And it doesn't have to be anything that's on this list. It can be, from peer review articles that, your trauma medical director went out and, or if your trauma medical director attended, or someone from the orthopedic service. It doesn't have to fit, in a specific box. We're just asking if you're providing, if you have an internal education process, how are you doing that? How are you documenting that? What platform are you using? Who's doing it, and how are you, how are you tracking that? Are you reviewing that through your PI process? Is it part of your PI process, etc.? So there's different ways to capture this. And the next couple of slides is going to talk a little bit about, like this one talks about, does a receipt email with an attached journal article count for internal education hours for physicians? Yeah, it does. It certainly does. And again, what the reviewers are going to ask is, well, yeah, that's great. So show me how you're doing this. Are you using SurveyMonkey to send this out to all your trauma panel members? How are you recording that? How are you tracking the hours for this? And again, several ways to do this. There's an algorithm in our website that shows who should be doing this and who should be doing external. This can be either your panel members, they can do external or internal. Again, talking about CME, prorated, I won't spend too much time on this, but for new trauma centers who are going to be verified or new consultation programs that are coming up, yes, we do prorate the CME, and there is really no benchmark on what that number is, but we ideally like to see 16 hours of CME if possible. What we don't want to see is 0 CMEs at a time of a site visit, that unless they're super new, just started your service within a month. Again, internal CMEs, how do you account for equivalent of, the IEP now has to be worth 16 CMEs. I currently do 1 quarterly. How do we know if it's equivalent? The rule of thumb is if we do hour by hour. So if it takes your panel members to read a document an hour and do a quiz in an hour, within the hour rather, then it's going to be an hour of CME. It's the same for if you're attending a conference and, the course is an hour long, they get 1 CME for that course. Operating room availability. How should trauma centers measure or prove an operating room must be adequately staffed and available within 15 minutes? Again, various ways to do this. The expectation is that the operating room team is notified when a trauma patient comes in, and the initial call and the team members respond. Their response times are tracked. And again, this can be done on a logbook in the OR. It could be done through EMR. It could be done through a back swipe, or it could be done through a scribe as well. So different ways to do this. There's not really one set way to do it. Interventional radiology. Question is, what types of interventional radiology procedures fall under the 30-minute rule? We haven't specified what those procedures are, so that's going to be institution defined. Again, question about when does the clock start and stop for the 30-minute response for IR? Easy. The clock starts when the call is made or the request is made for them to come, and the clock stops when the radiologist arrives. So that will count for the 30 minutes. Trauma Peer Review Committee. If this is talking about the trauma member, the liaison who cannot attend, and is there an alternate method to this? The answer is yes, there is an alternate method to this. So the requirement is that they have to be in person, or they can attend by web conferencing or teleconferencing. We do stipulate the teleconference fee be limited. There has been a recent change to this requirement that it no longer needs to be just the liaison. You can appoint someone, one person, to attend in lieu of the liaison. So it could be the liaison or just one specific person. Level 3 trauma centers, can the surgical director also be the trauma medical director? Yes, they can. This is true for level 2s and level 3 trauma centers, so your trauma medical director can also be your director or co-director of the ICU. This will differ for level 1. Credential providers. Question is, can you give us some examples of where a credential provider has to be available within 15 minutes? There's a scenario where the patient returns from the OR post-operatively. If something goes wrong, the nurse notices something, the blood pressure's gone down or there's blood gushing everywhere. The goal is that you want to get a provider, a surgeon or attending to be at bedside immediately. You don't want to wait for this, and again, you want to PI these instances. Other surgical services, lots of questions surrounding this. Again, this is a new requirement for level 2s. Level 1, level 2s must have the same subspecialist with the exception of cardiac surgery for level 2s. The expectation is that they are available in person when the trauma surgeon requests a consultation. They are not to do this via phone or telemedicine or web conferencing. Again, it has to be in person. Transfers for specialty care. How would you define an acute transfer? Please refer to page 84 is really what I can say. If you don't, it talks about what patients we're referring to acute transfers, your burn care, your microvascular. I want to clarify, microvascular, we're talking about replantation. If there's a lost digit, that's who you want to transfer. We're not talking about all other acute injuries, cardiopulmonary bypass, and so forth. So there's a list on page 84 that you can refer to. Advanced practitioners, wow, lots of questions on this. So let me just say, we use the terminology advanced practitioner, physician assistants, and mid-level providers interchangeably through the Orange Book, as you probably have noticed. I just want to make that clear. The expectation is if these providers, the ones I just mentioned, are part of your activation team and they respond to your highest tier and your second tier activation codes, and they're hands-on with the patient, meaning they are evaluating and resuscitating the trauma patient, they must be current in ATLS. We're not asking your scribe nurse who's part of your team to be ATLS current, or your orthopedic PAs or your neurosurgery PAs. We're talking hands-on. If they're hands-on with the trauma patient, for your high tier, your second tier, they must be current in ATLS. We're not referring to consults or your fast track either. Universal screening for alcohol. What SBRT information do surveyors want to review? Well, they want to review the reports for the patients. Again, they're going to look at this in your case reviews. They're going to pick this up. So what they may ask for, if it's not already in your case reviews, they're going to ask for a report on your admitted patients, who was screened, and who received an intervention. And again, they're going to pick it up in your case reviews. We don't have a cutoff age for SBI. The institution is going to define that for the pediatric patient population. If it's 12, that's what we're going to hold you to, and that's what we're going to review. Again, no cutoff age for the elderly. Research, if it's a combined trauma center, it's asking if it's 50%. No, we're not asking that it's 50%. It could be a combination of either adult or pediatric publication for combined trauma centers. There's no defined number for that. NCDS patient inclusion criteria. This is the link I was referring to for the National Trauma Data Standard Dictionary that you can go to. So a lot of questions on what types of patients we want to capture in your registry or for verification purposes. As Tammy talked about a little earlier, we are following their standards. So if you refer to the NCDS on page 4 and page 5, there's a beautiful diagram there that talks about what patients you should capture, and we're following that exact diagram as well. Non-surgical admissions. Lots of questions around this, and I'm not going to spend too much time on it. I did provide a sample, which will be available again later on YouTube. The next couple of slides is going to talk about it. But non-surgical admissions, again, you know, the admitting policy is going to be defined by the institution. You know, the goal is that the patient, if it's a non-surgical admission and the trauma service admits it, that, you know, they can hand that off to the hospitalist because they had a non-surgical or a surgical consult. Let me rephrase that. So lots of questions on it because some places want to admit them to the hospitalist or to medicine. That's okay. That's okay if they do that, as long as that trauma patient had a surgical consult. It doesn't have to be admitted to trauma service. It could have gone to neurosurgery or orthopedic. But, you know, we're just saying, you know, consider the best practice in terms of consult with the trauma service. Again, here's the breakdown of how to capture that, but this is where I want to show you is the diagram on how we're wanting to review this. So if you take from this slide the numbers and you break it down of how many patients you had that were admitted to non-surgical by your trauma admission, you see here this was a little over 10%. So you're not going to get a deficiency that you were over 10%. That's really not what the deficiency means. We're asking that you look at your trauma consults as you see here and you break it down and that you review them in your PI process. And that's really what the requirement is, that you're reviewing those that are over 10% in your PI process. Again, this slide will be available on the YouTube.
Thanks, everyone. Molly did a great job of presenting, and you too, Rachel. This has been great. So I hope this was helpful for you guys. Be watching your inbox for an email regarding your CE. We're going to try to do this monthly. If you'll notice that I tell you, we had over 100 questions, and we really had to, some were duplicates, so we really had to, you know, kind of calm them down on what we were going to present today. So if your question wasn't answered today, remember Molly's going to be reaching out to you within the next week. If you have, sometimes we tend to go a little fast to get all the questions answered, and so just know that this will be posted, and we'll let you know how it's posted, and you can go to this and refer back, and you can kind of just go through it at your own pace if you want to refer to something that we've talked about today that you didn't quite understand. So have a great day, and we will talk to you again next month.
Thank you, Trauma Verification staff, and thank you everyone for attending today's webinar, Trauma Verification June's Q&A Web Conference. If you have any other questions, please contact COTVRC@facs.org. On behalf of our presenters, thank you for joining us today, and have a great rest of your day.